Welcome everybody to our fabulous breakout session on driving real change with real world data. This session was organized by Sarah Halvik from Comagine Health and will be moderated by Katie Cadigan, also from Comagine Health. Today's sponsor is the Peterson Center on Healthcare, a longtime NADO sponsor and supporter. Thank you again to Lance and all his team at Peterson Center on Healthcare. At this point, let me go ahead and bring Katie on stage. Katie? Go ahead and take it from here.
Thanks, Norm. And hi, everybody. It's great to have you here. Thank you for joining us today. We have a great lineup for you today. We have 3 presentations. First up is Rebecca Matthews and Eric Tranby. They're going to present Extending Data's Role in Improvement, Project Planning, and Impact, Informing and Connecting Oral Health Integration Through More Care. So I'm going to turn it over to you, Rebecca and Eric.
Hello, thanks for joining us as we talk this afternoon about data's role in improvement, project planning, and impact. I'm Rebecca Matthews, Director of, all right, let me start over. Sorry for that. Let's go again. Hi, thanks for joining us as we talk about data's role in improvement, project planning, and impact. I'm Rebecca Matthews, Vice President of Health Improvement at the CareQuest Institute for Oral Health. I'm joined by my colleague, Dr. Eric Tranby, Director of Analytics and Data Insight. Next slide. So research continues to show the connection between oral health and systemic health, including that 5 of the 10 most common chronic diseases have an oral health connection. Consumers get that too. Surveys by the CareQuest Institute show that 96% of adults know there is a connection between the health of the mouth and the rest of the body. Also, that 7 in 10 adults rate oral health about as important as their physical health, while 1 in 4 rate it as more important than physical health. So despite the oral systemic connection being known, we find that our oral healthcare system is often siloed from medicine. An important step to bridge that gap is efforts towards medical dental integration. But coordinating care between medical and dental is not easy. There are a few key reasons for that. First, these systems operate in silos. They have historically, and that continues today. There's also a lack of information on all sides, and that it's not shared between patient and provider, be it medical provider or dental provider. And then also, the sharing of patient information provider to provider is lacking. Finally, there's unique communication processes in each practice or clinic that add to that difficulty in standardizing tools to communicate and coordinate care. So an effort we have taken on to address that is called More Care. More Care stands for Medical Oral Expanded Care. It's an improvement project by the CareQuest Institute focused on addressing these barriers by first integrating oral health better into primary care settings, while also promoting referral networks being established between medical and dental practices. So More Care will be operational in its 6th state later this fall. I will now talk a little bit more about how, through the history of this program, we've been able to enhance data's role in its design. So within improvement projects, data is necessary to understanding the current system, the existing infrastructure, where the barriers are, and then what enables positive performance in the system. It allows us to set our baseline for which we strive to, find improvement and compare our results after an initiative's over. We also recognize that in, the use of data in our oral health system, it's a complex system. It's not static, it's a dynamic, and there's a system and there's no single source of data that can help us understand how any complex system behaves. So thinking of our oral health system, we need several data sources to see how a complex system in healthcare is performing. It's that recognition of the need for multiple resources or multiple sources of data to better understand the current system, to establish baselines, and to know what we want to improve. And while this is science, it's also human. People are critical players to the oral health system from multiple vantage points and levels of influence or impact. So as we think about using data and using rubrics to inform, what we know about our current system, also kind of adding that human focus through design thinking really gives us an opportunity to ensure that we're extending beyond the collection of data to the empathetic learning process. So this mixed method approach of data collection both aids in understanding our needs, building relationships, and also making sense of what we want to learn. In our planning process for MoreCare in Ohio, we've enhanced our usual data collection, which includes dental and medical utilization data, insights into care infrastructure, health outcome rankings, and so forth. And we've done this in two ways. First, to broaden the area level measurement, we can leverage to bring in deeper knowledge of sociodemographics and their impact of social determinants of health, looking at these not only at the state level, but through a meso and micro level in order to better understand regional distinctions that inform more about community level characteristics and needs. Secondly, we've matched this focus on understanding regions and communities through qualitative market research to give us a deeper context through consumer insights. A fantastic resource we've been able to leverage is the Ohio Opportunity Index created by the Government Resource Center at Ohio University. This Opportunity Index provides area level measurement on socioeconomic and structural conditions across 7 domains, which you can see listed to the right hand of the slide. The Opportunity Index really synthesizes numerous complex data sources to help us understand where opportunities levels might be high or low across Ohio's communities. So with that, I will turn it over to Dr. Tranby.
Thanks, Rebecca. And in my part of the talk, I'm going to talk a little bit about the use of data for assessing the impact of programs. One of the things that is an important component of everything that we do is evaluating program effectiveness, in addition to some of the program data for program planning that Rebecca spoke to. Program evaluation involves making sure that that there are common understandings of the purpose and the outcome of the program, describing the program in detail, focusing the evaluation, gathering evidence, both quantitative and qualitative evidence, both for planning and evaluation purposes, and then disseminating and sharing the results of that data. We get data from a variety of different sources. When in the evaluation exercise, we collect from existing systems, primarily clinical data and financial data. And so we receive direct data from EHR systems, as well as some financial data from the clinics from the beginning and the end of the program. We also collect participant data. Those may be notes from monthly calls or data from interviews or surveys with patients, providers, staff, and program leaders. The outcomes that we measure are driven by theory of change. I'm not going to walk through this whole driver diagram, but just want to make everybody aware that while we are tracking individual outcomes, those outcomes are the result of a series of interventions and thinking that is serious thinking that is done about what the impact of the program is likely to be based on those outcomes. In past iterations of MoreCare in South Carolina, Colorado, Pennsylvania, and Oregon, we have tracked things like fluoride varnish, risk assessments performed, and oral health evaluations. Some of the results that you can see here show the increased use of fluoride varnish in pediatric populations across MoreCare clinics between different stages within the learning community process. And so really shows that there's been an increased use of fluoride varnish over time, and that this impact persists beyond the scope of the program, with similar rates of fluoride varnish being applied to pediatric populations up to 18 to 24 months after the intervention has ended. Broadly, our evaluation shows that the MoreCare initiative is effective in creating an operational structure, integrating oral health into primary care, that we have a lot of success when readiness criteria are met through a whole team approach. There's strong leadership buy-in, and there's good health information technology capabilities. And sustainability tends to be achieved in practices where there are customized solutions that address the needs of their communities and patient populations. Thank you, and we'll now take your questions.
Thanks, Rebecca and Eric. Appreciate that presentation. One of the things that stood out to me was listening at the very end, Eric talking about how the highest sustainability solutions are ones that are customized to the needs of the community. So I'm wondering if you all could speak more to that effect, particularly any insights into the community and how to understand what its needs are.
Yeah, thanks, Katie. And I'll definitely want my colleague to jump in too. But I think here, as we think about the determinants of health and, going back to the health field model, just there's the recognition of the impact that your physical environment, your social environment have, and that communities have unique characteristics there. And so I think for us, it's the recognition of the need not only to understand the current state of a community, socially, environmentally, and those impacts that can be had on health, but also what that means in terms of the capacity for health care delivery supports and other supports in a community. So it's really making sure we are looking that broadly at the context of what's there now in terms of environmental factors or social factors, and also the presence of healthcare infrastructure.
And to build on that a little bit, a key thing that we work to do within our initiatives is making the data and analytics that we find available to our clinical partners and our community partners for response and feedback. We find those are most helpful for goal setting when we have a lot of voices at the table, rather than just a payer or a clinical advisor setting a benchmark or metric, but rather really understand where those particular providers are coming from, the communities in which they serve, is really very helpful for setting realistic targets and benchmarks that we can work with those clinics on.
Thank you both. Folks on joining us, remember that you can use that chat feature to add any questions or comments, and there will be an opportunity after our third presenter for a larger Q&A. So keep in mind what you'd like to ask and find out more about at that time. Well, Rebecca and Eric, thanks again. Appreciate your time and information. And I'm pleased to turn things over now to our second presenters, Valerie Garrison and Benjamin Hochschild from the Center for Improving Value in Healthcare. They are going to present enhancing the Colorado all-payer claims database capabilities through evaluation services. So welcome, Val and Ben. I'll turn it over to you now.
Good afternoon. I'm Ben Hochschild. I'm the Evaluation Program Manager at CIVIC, the Center for Improving Value in Healthcare, and we are the administrator of Colorado's APCD. We're going to be discussing program evaluation and how we can use the APCD to evaluate program processes, outcomes, and impacts. And I'm going to turn things over to Val Garrison to speak about evaluation and our work.
Awesome. Thanks, Ben, and hello, everyone. Before we jump into our evaluation services, we want to acknowledge that not everybody on the call might be familiar with evaluation, so I want to run through really quick what it is and why it's important for this context. So evaluation is the systematic use of measurable feedback to study a program, innovation, intervention, or practice. And the real purpose of that is to inform decision-making. We have limited resource and really specific goals, and we want to make sure that we're investing those resources into projects that are achieving those goals. And this process relies on high quality data. So as we'll hopefully demonstrate, this is where the APCD comes in and really shines. I like to think of evaluation in the context of research. It's really helpful for me to understand it as a type of research that has a very different focus. So while research is really focused on answering a question or observing something about the world and contributing to the generalizable knowledge of science, evaluation is really focused on a specific program or project and is outcomes focused. So we want to be making practice recommendations to our stakeholders that really are tailored for those specific projects. That said, the methods and all of that are really the same, and the process is similar between research and evaluation. There are 4 main types of evaluation that shift our approach, stemming from formative evaluation, where we're identifying the needs, we're planning and designing, going through to process evaluation. So are we doing what we said we would do, and are we doing it the way we said we would do it? And then the outcomes. Did we have the direct outcomes that we were aiming for in our program? Did we achieve a certain number of people in a certain population receiving a certain vaccine, for example? And then the impact evaluation is really looking at what were the effects that kind of extend beyond the scope of our program. Maybe we improved vaccine rates, but we didn't actually have an overall impact on the rates of disease among that population that we worked with. Impact evaluation is what most people look to when they're trying to think about evaluation and what they can understand from their data, but it's also one of the hardest to really show improved direct impacts from a program to a population. And part of the issue with that is the access to the high quality, reliable, individual level data. And of course, that's where the APCD really holds value. So let me give you one quick example of a project that we did in 2017 that highlighted the need for us to provide more of this evaluation service to our change agents. Project Angel Heart provides free medically tailored meals for patients with chronic conditions. But up until that point, they were entirely dependent on philanthropic contributions to manage this program. And they were receiving anecdotal feedback from their clients that were essentially saying, your meals saved my life. And Project Angel Heart wanted to know, how can the Colorado APCD demonstrate this value using the data from claims to turn this one saved life into many? And so we conducted an evaluation. We did a patient matching project with their data. And we demonstrated that those who received Project Angel Heart meals saw a 13% reduction in the rate of hospital readmissions. They saw a reduction in the total cost of admission of up to $555, and then total overall reduction in overall medical costs of about 24%. And those are huge outcomes for their patient population. The impact of us doing that evaluation for Project Angel Heart was they were able to coordinate with healthcare delivery and payment models to integrate this program into the direct continuum of care. And they were able to negotiate with Center for Medicaid Services to have patients who are of lower income or receiving Medicare services to not have to worry about where funding for this food comes from. They were able to receive this benefited service through their own health insurance. So with that example, I'm going to turn it over to Ben to describe, looking at examples like that, how we do what we do to provide these services.
Thank you. So I'm going to be speaking about how data housed in the Colorado APCD can be used in evaluation and provide some examples of the types of evaluation services we can provide. This is a very oversimplified schema of the difference between what a data request that comes to our analytics team and what a request that comes to our evaluation team looks like. For a data request, once an agreement is reached and the parameters are set for a project, the analyst will go ahead and pull the data, do the summary tables, it's delivered to the client, and then that organization could take that information, create their own graphs and charts. They could write their own reports, they could create their own presentations, but that's all in their hands at that point. With an evaluation project, once we've gone ahead and set the parameters for a project, we'll pull data from the APCD, but we'll also pull data from other sources. That could be surveys that they've conducted or surveys that we've created for them. We may pull data from the American Community Survey. We can integrate that into the analysis that we do. We're able to create infographics, including maps, which we'll be talking about in a minute. And then we can provide them with a custom evaluation report, custom slide deck, or infographics for their websites. So here are some advantages of using APCD data for evaluating programs. We can provide data on healthcare trends and patient demographics. We have provider utilization data, and of course, being claims data, we can provide information on cost of care. Recently, we geocoded all of the data within the COAPCD, and that allows us to conduct more comprehensive geographical analyses than previously. So this is an overview of the evaluation services that we provide. We typically start with project planning. That might include conducting a needs assessment, creating a logic model. Moving into implementation and analytics, we are able to provide summary and statistical analysis. We can do cost-benefit analysis or other types. In terms of deliverables, as I mentioned before, we can provide evaluation reports, infographics, custom slide decks, or create toolkits for change agents. And then for capacity building, we can draft evaluation plans for grant proposals. We can assist with drafting evaluation plans for grant proposals. We can also provide training around data numeracy and education, and provide organizations with tools and resources. So claims data can help address some common limitations. As we mentioned previously, we had all of the data in the APCD geocoded, and that is a powerful way for us to conduct geographical analysis and help identify access to and use of care. Previously, we were limited to relying on point-to-point analyses. And this is an entirely hypothetical example, and it isn't real data. But if you wanted to calculate the median driving distance between a group of patients in the clinic they go to for care, you'd measure the distance between the geographical center of the census tract, zip code, or the county where the patient lives to the center of the census tract, zip, or county where the clinic is. And then that's just a straight line. It doesn't take into account things like long rural roads. But with geocoded data, we can see an entirely different picture. What you see in blue is, again, hypothetical, but if we have an accurate location for the patient and clinic and can map a driving route, we may actually see that what we thought was a relatively small median driving distance could actually be much longer than we previously thought. This is, again, just a sort of representation of that. You can see, particularly in Colorado, many of the hospitals and hospital systems are located in Denver. People who live west of Denver in the mountains can have some very long roads to drive through in order to reach care, and measuring point to point just underestimates the actual distance that they're driving to access care. So here are some sample use cases we discussed as possible evaluation projects. We have examples for foundations, funders, and payers, for nonprofits and community-based organizations and hospital clinics. We'll go ahead and I won't go through all of these in detail, but different organizations may have different evaluation needs, and that's something that we can respond to with a combination of APCD data and data that they might provide themselves. So I'd like to thank everybody for listening to us. On this slide, we've provided our contact information. Please feel free to reach out to us with any questions. Thank you for listening, and thank you to the organizers at NATO for the opportunity to present. Thank you.
Thanks, Val and Ben. I enjoyed the specific story about how you all used evaluation services with a community-based organization providing meals, and that demonstration of how evaluation can replicate that and show, value to increase funding. As an analyst by training, I feel very competent in analysis, and sometimes there's this assumption that therefore I know how to be an evaluator, which is not at all the case. And I appreciate that you all highlighted the difference there. I'm wondering if you could speak a little bit more to that difference, for example, between an evaluation plan and just a typical analytics report or data pull, and particularly what the APC data tells us about that difference.
Hi, certainly. So we tried to highlight that on one of the slides. Typically, well, first of all, the main difference between the analytics requests that come into Civic versus the evaluation request is analytics requests are probably a magnitude of order higher. They're typically projects that can be completed in a shorter period of time, whereas an evaluation project may take 3 months or longer. with an analytics request, it's really focused on pulling data strictly from the APCD, providing summary or a data set back to a client. Whereas with evaluation, we do need to work a little more closely with the client ourselves. We need to get to the evaluation question that they're interested in asking or answering. We then will develop an evaluation plan with them. We'll review that with them. We'll identify which outcomes they're particularly interested in. We'll identify what type of evaluation needs to be conducted, whether it's an outcomes evaluation or if they really want to do an impact evaluation, which, as Val mentioned, is usually the most difficult type of evaluation to conduct. And then in terms of deliverables, what we return is more like a research report than a standard data set. So those are the main differences. And I like to say it's much easier to turn a data analyst into an evaluator than an evaluator into a data analyst. Once you learn the basics of evaluation, it all sort of makes sense, and everybody goes, "Oh, I do this already." Everybody does evaluation in some capacity, whether it's being part of an annual performance evaluation for your job or taking part in a survey from Amazon about how whether you like their product. That's a type of evaluation.
Yeah, and just to thanks, Ben, and to expand on that, I think this really builds our opportunity to collaborate with our change agents in a whole new way of working with them to understand and do some capacity building around gathering and interpreting their own program data and being able to, we can build tools and processes for them to track this information over time and understand at a glance how their program is doing. And, we talk a lot about as analysts, we have a deep understanding of the claims data and the process and what all that data means and how to manage and understand it. And what our change agents bring to the table is that really deep understanding of the community and the population and the specific health focus that we're trying to understand. And it really gives us an opportunity to bring in, working with teams that are addressing the social determinants of health to improve health outcomes. And an additional piece, I kind of alluded to this in our presentation, and I think Ben touched on it as well, is there are some limitations to using healthcare data, in terms of ensuring that we're protecting the privacy of patients, that simply just limit the ability of these programs to evaluate their outcomes because they don't have access to that data. And so if we're able to do that analysis in-house and really draw those patterns and conclusions and work with the change agent in understanding them, that opens up a new world. So for example, a funder may not know if they're having an impact on access and drive time, and they would never have access to that point-to-point information, as Ben gave the example for, but we can do that without releasing PHI. So those are just a couple of the extra benefits that we're exploring and I'm pretty excited about.
Thanks, Ben and Val. Got a question here from the audience. Morgan Talbot says, who identifies as an evaluator. And Morgan says, when I propose evaluations to get projects started at the health department, I find they go along with the menu of services I suggest throughout the project without really generating original ideas. What are some tips, Val and Ben, that you have about generating genuine interest for evaluation? Thanks for that question, Morgan.
So glad to hear from a fellow evaluator. So we also do have a menu of services ranging from a simple analysis all the way up to a complete impact evaluation. But what we do when we start a project is we like to have a one-on-one. we kind of call it our initial interview, where in very, very plain language, we begin by asking them questions like, instead of what is your evaluation question, we may say, or what we actually have written down into our script is, what do you want to accomplish with your evaluation? What do you want to find out from your evaluation? So we really tried to keep it focused on our partner, let them drive the process and tell us what they want. And then we talk to them about the best way that we can achieve that and what data we would need to do that. We also ask them questions about what data do you have available? And if there's a use case for it that they might not have considered, we might propose that.
Yeah, and two of those questions, just to add to what Ben said, that I really love to ask is, what does success mean for you? And what does that actually look like? How do you know, like, that you can definitively say, yes, this made a difference?
Thank you, Val and Ben, and thanks again, Morgan, for the question. All right, with that, I'm going to present our third presenter, Jacob Zelko from the Georgia Tech Research Institute. Jacob will be presenting his work on using the APCD Common Data Layout with the OMOP Common Data Model. So with that, I will turn it over to you, Jacob.
Hello everyone, my name is Jacob Zelko, and thank you so much for coming to my talk, APCDs in the OMOP Common Data Model. To give a brief introduction about myself, I'm a health data analytics and informatics researcher at Georgia Tech Research Institute. Moreover, currently, I'm developing or supporting the development of the analytics core component of the Georgia APCD. Furthermore, I'm the current lead principal investigator of an observational health research study focused around characterizing chronic mental illness across the state of Georgia using observational health data such as patient claims information. Seen on the right are some of my hobbies such as playing guitar and traveling the globe. Diving right into this talk, let's start with talking about the difficulties in data sharing. As many database architects, engineers, and database users themselves know, data sharing architecture can be very complex. The trade-offs between data transparency, patient privacy, and security are questions that every single database maintainer will have to face, as well as APCDs are no exception to this problem. So the question is it possible to interoperate with APCD standards? Can we derive quick wins from APCDs using interoperable data standards? Well, the good news is that in the APCD community, there has been limited adoption of a data sharing model. This data sharing model is known as the APCD Common Data Layout put forth by NATO. Several states across the United States are in the process of either implementing it or looking at how they can use it for their APCD. However, for a variety of reasons, states also are running into issues of using the APCD Common Data Layout, so rendering them incapable of pursuing potentially interoperable data standards. And that gets back to the question of how do we derive quick wins from patient claims data? Seen here is an example of CMS Medicare data, Medicare and Medicaid data. This data is fake, but the complexity and the problems of how do we work with such amounts of data is very, very much real. For that, I'd like to introduce what is known as the OMOP Common Data Model, or OMOP CDM for short. So what is the OMOP Common Data Model? Well, its purpose is to ingest real-world data such as patient claims information and break it up across the database in carefully created and maintained tables, such as a person table, drug exposure table, or measurement tables, so on and so forth. All this information that can be gathered from a piece of patient claim information. So the question might be, the OMOP CDM, why should we use that? Well, I present the OMOP CDM to say that there has been extensive adoption and support through this particular data model and data standard through an organization known as Odyssey, the Observational Health Data Sciences and Informatics Initiative. Odyssey is an extensive international community with over 2,000 individuals nationwide pursuing research with the OMOP CDM. Moreover, the reason why the OMOP CDM has been so powerful for researchers in this community is that it does enable quick analytics. Furthermore, the reason why I present this is that I'm very excited as there has been initial research done on mapping the OMOP CDM to the APCD Common Data Layout. And to hammer home why I think the OMOP CDM or utilizing the OMOP CDM could be really useful in conjunction to or as a complement of the APCD common data layout is a case study focusing around my research study on characterizing health disparities in chronic mental illness. For this case study, I'm going to present results on using data that's already readily available in claims and show how we can generate patient subgroups and populations across axes such as conditions, race, age, gender, location. Furthermore, that picture on the right isn't just a picture for fun. We also get at the idea of intersectional subpopulations, characterizing subgroups by features such as their age, race, gender, and conditions, for example, to generate one such subpopulation. As I mentioned previously, this case study is around disparities in chronic mental illness, and we've been exploring bipolar disorder, depression, and suicidality. There's been two characterizations in particular that we've been examining, which is a baseline characterization, which is focused on patients who have received at least one care for one of these conditions, and the follow-up characterization, which is individuals who are seen only once for care for one of these associated conditions. For this case study in this talk, we're going to talk about the baseline characterization. So we characterize baseline depression in particular using approximately 2.2 million Georgia Medicaid subscribers in this data set that we were using, and this was formatted in the OMOP CDM. Furthermore, the data was from 1999 to 2014. For those curious, we used the MAX personal summary file, inpatient file, other services file, and the prescription drug file. We calculated prevalence rates simply as a first pass at addressing this characterization study. Seen here an example of some of the results that we can generate using these metrics and using the data that's available. Subfigures A, B, C, and D break these patient subpopulations down by race, and then we break it down further by age groups and genders. And again, this is looking at crude prevalence of depression in Georgia subpopulations with the crude prevalence rates on the y-axis. Early insights on this analysis is that if we compare these minority populations, such as Black or African American, other races, or Asian populations, to the majority populations, i.e. the white population, we can see that there is differences in prevalence rates. In particular, the boxed prevalence rates shown in the red boxes that you can see are those prevalence rates where the minority population actually has higher prevalence rates for these conditions as opposed to the majority or white population. Furthermore, moving forward, if we collapse these subpopulations down and don't look at things such as gender, we can actually see different results in different populations being represented or shown differently across or against the white subpopulation groups. As shown here, we only see 2 subpopulations. Previously, when we accounted for gender, we saw 5 at least. This presents further research avenues and questions that we can address in future aspects of this study. However, though, it brings us to the conclusion of this talk, which is, can you generate insight from data? And my answer is a resounding yes. You can generate insight from occupational health research data and derive quick wins from the same data that goes into the all-payer claims database. The great power behind how you could utilize patient claims information in, say, for example, the OMOP common data model is that you can run analyses or implement analyses once and then run these analyses everywhere. So for those APCs who can interoperate in the future potentially with the OMOP common data model, there could be multi-site collaborations occurring or different partner sites being able to loop into a collaboration effort. Finally, my strong opinion is that as a community, the APCDs shouldn't reinvent the wheel. Instead, we should bring the APCD to the OMOP common data model to utilize all the tools and resources built around the OMOP common data model as is. So with that, if you have any questions, feel free to contact me at either of these locations. And with that being said, as my talk there is saying, thank you so much for your time, and we hope you have a wonderful rest of the day. Take care.
Thank you, Jacob. I appreciated in particular the way that you demonstrated how the APCD and the OMOP model can be used to identify disparities and then, inform interventions to improve the system to better meet the needs of folks that we're not serving well. I'm curious your thoughts about how this approach that you've described can be used in analyzing or characterizing care delivered by specific providers.
Yeah, so as I kind of showed during the presentation, it really goes by a somewhat of a site by site or case by case basis, depending on the data that is available. But in this case, using the tools such as the OMOP CDM in conjunction potentially down the road with the APCD common data layout, if a submitter or site does have access to this sort of provider information, that data can easily be mapped or translated into the OMOP common data model standard. And then from there, that analysis that I was showing, that case study on the disparities with chronic mental illness, what could then happen with that data is that you could either use some of the tools that are pre-existing around the OMOP common data model and just bring in that provider information, or you could invent novel tooling around how you want to slice or characterize provider use in a given scenario that you have in mind.
Great, thanks, Jacob. So folks, this was our third and final presentation of the session. And now we have the benefit of being able to bring all of our presenters back on the screen. Thank you all for your time. And audience, I hope that you all have been thinking of questions or thoughts or reflections that you have to share for our presenters. I'm going to give you a few more minutes and start with one of my own. So one of the things that struck me in listening to all three of your presentations was just the way you all used different mixed methods to incorporate both qualitative and quantitative data into the work that you're doing. And so I'm curious if any of you all would speak more to both the opportunities and challenges that come with mixed methods and multiple data sources, including qualitative and quantitative data.
Yeah, I could jump in first if that's if that's all right with everyone.
Please.
So the great thing, so there's a couple of interesting quirks about my area of how I approach the problems that I was addressing, and some of those quirks is that certain sites, depending on where you go to throughout, it could be throughout the United States. Depending on the different sites, not everyone's going to have the same data available. So figuring out, how you could even do apples to apples comparisons is a science in and of itself. So it's a bit of an open question about how, say if one site doesn't track, these sort of disorders or these sort of conditions around, like, in my example, like depression or what have you, then it can be a bit challenging to not only figure out how to do apples to apples comparisons, but also crosswalk data across different sites to make comparisons overall. So that's just one of the interesting quirks, or I wouldn't say really quirks, but open research areas that myself and other researchers are still working on with the approaches that I'm using.
I would say using qualitative data really can provide a lot of context and insight into the quantitative data that we're collecting. Often, if we just look at quantitative data, we have an incomplete picture. But the supplementing that with either survey data or key informant interviews or other types of qualitative data can give us a fuller picture and can help us answer questions that that may be more challenging.
That's very similar to what I was about to say. And so my background is most of my career was spent in nonprofit program management. So on the more data user side of this world. And I noticed numerous times having a data set where you could have two completely different and seemingly opposite truths coming from the same data set. And so providing that context through the qualitative depth of understanding, through those community partnerships and collaborations to obtain that qualitative data and really understand the community context of the data that we're looking at can really help us do what Jacob was demonstrating and use that data to break it down and identify those insights of why is our community seeing this differently than we are as analysts and researchers? And I think it's just a critical step to get the whole picture. It's deeply important for equity.
Yeah, building on what has been said to this point, I think both the benefit and challenges of mixed method design are what they reveal about differences in motivation and drivers for programs. You often see going into this that key stakeholders had, when you're doing these qualitative interviews, that key stakeholders may have fundamental differences about what the program was meant to achieve or meant to target, that have to be kind of rectified as part of the evaluation. Both as part of the evaluation and implementation cycle. And so in our view, program implementation and program evaluation go hand in hand and are really a kind of a cyclical process, because you learn a lot as part of that evaluation exercise that can feed into the next time you're doing programs or similar type of programs. So our programs tend to build on each other in that way, trying to get a better sense, push the program forward. What are the next challenges or opportunities that we have with this particular line of work in this particular program? And that evaluation process kind of helps reveal that and can also help demonstrate, as I said, when kind of key stakeholders have different views of the benefits of that program or the interpretation of the data, as Val points out, are all very helpful. So to us, those mixed methods are crucial for understanding both what we observe in the data and for actually making a program or initiative more successful for a wider array of stakeholders.
I just want to add that there can be some hazards to using qualitative data that don't typically come along with quantitative data, and that is sort of an evaluator's worst nightmare is when you get a survey that was designed by a partner and you didn't have an opportunity to review the questions before, and you see a question like, how did you find the program? And half of your answers are, oh, it was really wonderful. And the other half are, oh, I used Google Maps. This sort of misunderstanding of what the question is can be very problematic.
Thank you, panelists. I appreciate your input on that question. Audience members, I have an ask of you. I would love to see in the chat, in addition to any questions or thoughts you have, just reflections on what you learned today that feels most applicable to your current work. In the meantime, while I give you all a few minutes to think about and add that, I do have another question for our panelists that came up for me as I was listening to y'all answer my first question. Val, you brought up specifically the, equity. And as I listened to each of your presentations, the ways that you are involving communities' needs, right? The way, Jacob, you had talked about the intersectional identities and pulling in different aspects of people's identity and your demographic data. So I'm curious if any of you all have any more thoughts about the specific ways that you see the work that you are doing, that you described here today, impacting health equity, right? Changing our systems to better meet the needs of folks that our systems has not historically and still continues to not currently serve. So I'd love to hear wherever you want to take that question.
I can jump in, Katie. Referencing back to our presentation and a programmatic implementation we're taking on right now in Ohio, we use that as kind of an example of our work in implementation of improvement programs using data. I think the opportunity we saw, again, using a mixed methods approach to join both what we can find around utilization data showing access to care and disparities there across populations, layering that in with area level measurements that could help us to get some more insight into where barriers might be existing socially or environmentally that, are impacting access to care. So I think that's a place where for us, we, utilize that as really a way to get, in addition to some, consumer insight and, through qualitative efforts, some better understanding of what, opportunities are needed in a community. And that, beyond thinking around affecting access to care, we also have to keep in mind where there are barriers, social related health barriers that also need to be navigated. And that's an opportunity at the community level to highlight that and look for solutions that can drive improvement as well.
And to jump on to actually following up on what you were just saying actually just now, something that we've been thinking a lot about with some of the research that we've been doing at GTRI is thinking around that question of especially representation. When we look at, for example, in the demo or the case example that I was giving, which was on max patient data from Centers for Medicare and Medicaid, particularly Medicaid patient data. That data is only going to be representative of a very small subset, already of that particular state, which was in that case the state of Georgia. And so thinking about questions of representativeness, whether it be crosswalking to surveys such as the American Community Survey, or thinking about how could we weight against census level data to understand both the representativeness at all of our data to see how it might relate to the actual overall census populations for a given region that we're examining. And then, following on, asking the questions of, okay, if we know this is how representative our data is of these populations in actuality compared to the gold standards like the census, then, could we then possibly or potentially make any sort of inferences or insight into conditions or prevalences that we might want to be addressing? One particular, interesting finding with this case study, and I don't think I touched on it in my talk earlier, was the fact that with Asian populations, like Asian American populations, they're very poorly represented in the data that I was working with. And I don't think that's a function of them not being there. I think it's just a function of that data just didn't have those populations being well represented. So thinking about the implicit biases in our data is something not only myself I'm thinking on, but also I'm sure a majority of health equity researchers right now, especially as we try to derive value from real world data like APCDs, is also thinking a lot about.
Thank you, Rebecca and Jacob, for your thoughts on that. Kimberly, I hear you called out in the chat here, talking about the case example that Jacob provided using OMOP with max data. Jacob does have an example here of others that have used APC data in the OMOP, and I'm going to add that. Can I add that directly to the chat, Norm, or is that something that you can put into the chat? All right, thank you, Norm. So Kimberly, the link that's about to be added here is a link to another example.
And Katie, is there if I actually add a little bit more to address Kimberly's question?
Please do.
Yeah. So Kimberly, first of all, thank you so much for your time and being here. Great question. So there are two particular examples that come to mind actually right now. The one example that I think Norm will be sharing is the main APCD, where there is work actually being done to figure out how can we bridge between the APCD common data layout and the OMOP CDM to actually derive value from just that overall bridging effect. There's also work being done in West Virginia University right now, as a kind of shameless plug, if you will, for where the status of this bridging or this mechanisms are in place right now, is the fact that I'm currently spearheading efforts within the Odyssey community, which I mentioned in that presentation, to actually think more rigorously about developing this sort of bridging mechanisms, how we can think about bringing the APCDs into the broader field of real world data research or observational health research. And so if you want to get involved, feel free to follow up with me or contact me later. I'm happy to connect anyone with that group as that work is being done right now. I'm very excited.
Thank you, Jacob, and thanks, Kimberly, for the question. We do have 5 minutes left in this session. Again, so if anybody in the audience has questions or thoughts for our presenters, And I am still interested to hear how what folks learn that they can apply to their own work.
I was just thinking a little bit more about your question about equity and how these mixed methods efforts can contribute to incorporating that into our analyses. And so some may be familiar that Civic recently went through a process of geocoding all of the data within our all-payer claims database. And our purpose for doing this was so that we could get down to a more granular geographic level to better understand the communities from which the members in our database are coming. And so that's allowing us to really take a step back and use these external data sources. So social determinants of health indices, bringing in ACS data at the American Community Survey data at the census tract level rather than looking at the whole zip code. And that will provide value. It's still not an individual patient level indicator, but understanding the context of the communities where individuals are coming from will really help us in our analyses, and getting down to that more granular level is helpful. Some of the areas in which that becomes really important, especially in heavily rural states such as Colorado, is looking at access to internet usage. So for isolated populations, having a broadband connection and access to telehealth, and looking at those utilization patterns, and also having a better understanding of how state policies are impacting care that is offered to patients. So for example, Ben, I don't want to steal your thunder, but Ben recently worked on a gender affirming care public data bite to really understand, we were able to demonstrate a 300% increase in the number of Coloradans receiving gender affirming care between 2016 and 2021. And so being able to understand those social and environmental and state policy impacts on the members in our data set, really starting to explore these new ways that these other qualitative and quantitative sources can come in and enhance the data we have on hand.
I just want to add quickly to that. Colorado in 2021 became the first state to require Medicare and all insurers on the marketplace to provide gender affirming care as part of their covered services. So this increase we're seeing, we believe, is being driven by policy. We can't really make any other assumptions about why we're seeing an increase in the number, other than there's more access, which is a good thing.
Thank you, Val and Ben. Any other final thoughts from our presenters? Okay, well, with that, I want to thank each of you, Val, Ben, Rebecca, Eric, and Jacob. Thank you for your time and expertise today, sharing that with all of us. Folks joining us from wherever you happen to be, thank you for taking time out of your day to listen to these great presenters. And I hope you all found some information that you can use and apply to the work that you're doing. With that, I'll kick it back to you, Norm.